Welcome to PT MicroLessons, fast lessons with big impact. In this lesson, we're going to look at common lower GI conditions relevant to PT practice.
When we're trying to determine the cause of visceral symptoms, we're really using pattern recognition, not making a medical diagnosis. First, look at the location of pain or discomfort. That helps you narrow down the likely organ system. Next, consider symptom behavior when it occurs. Is it related to meals, activity, position, or time of day? Also, is the condition acute or chronic? And what is the typical age of onset? Then, look at the key features. Sometimes this comes in recognizable patterns, or even a triad. For example, the classic triad for diverticulitis is left lower quadrant pain, fever, and a change in bowel habits. Not every condition fits the triad approach, but it may help you quickly identify one. And finally, always screen for red flags because they tell you when to refer.
Now let's move into the lower GI system. This includes the jejunum and ileum, the large intestine, rectum, and anus. Common conditions in this region include appendicitis, inflammatory bowel disease, diverticulitis, irritable bowel syndrome, and bowel obstruction. As we go through these, we'll continue to use the same framework, looking at location, symptom behavior, key features, and red flags to help guide clinical reasoning. Let's look at appendicitis first. Appendicitis is inflammation of the appendix. Pain typically starts as vague periumbilical discomfort, then localizes to the right lower quadrant, an area referred to as McBurney's point, shown here with the red dot. Other factors to keep in mind are that the symptoms worsen over time and are often aggravated by movement or palpation. Also, key features include nausea, vomiting, loss of appetite, and low-grade fever. Lastly, red flags include rebound tenderness, guarding, increasing fever, and signs of rupture, such as sudden severe pain and a rigid abdomen. Next, let's look at Crohn's. Crohn's disease is a chronic inflammatory bowel disease that can affect any part of the GI tract, but it commonly involves the terminal ileum. One classic feature is skip lesions, meaning the inflammation occurs in patches, with areas of normal bowel in between. Pain is often felt in the right lower quadrant. A simple way to help remember that is that Crohn's has an R in the name, as an R for right lower quadrant. Symptoms are usually chronic and relapsing, with periods of flare-ups. Key features include diarrhea, abdominal pain, weight loss, and fatigue. Red flags include severe pain, fever, and signs of complications such as obstruction, fistulas, or malnutrition. Lastly, the triad for Crohn's disease is abdominal pain, chronic diarrhea, and weight loss. Let's move on to ulcerative colitis. Ulcerative colitis is also a chronic inflammatory bowel disease like Crohn's, but ulcerative colitis is limited to the colon and rectum, and there is continuous inflammation, not skip lesions like Crohn's. Pain is often felt in the left lower quadrant. A simple way to help remember that is that ulcerative colitis has more L's in the name, as an L for left lower quadrant. Symptoms are chronic and relapsing, with periods of flare-ups. Key features include bloody diarrhea, urgency, abdominal cramping, and tenesmus, which is the feeling of incomplete emptying. Red flags include severe bleeding, dehydration, fever, and complications like toxic megacolon, which require referral. Big picture for ulcerative colitis: the triad is bloody diarrhea, abdominal pain, and urgency. Next, let's look at diverticulitis. Diverticulitis is inflammation or infection of diverticula, most commonly in the sigmoid colon. Pain is typically localized to the left lower quadrant and tends to be more constant. Symptoms often worsen over time and may be accompanied by fever, nausea, and changes in bowel habits, such as constipation or diarrhea. Red flags include severe pain, high fever, and signs of complications like perforation, such as a rigid abdomen or infection, which require referral. One key distinction from previous conditions is that diverticular disease primarily affects older adults. So we will add that to our triad for diverticulitis, which is left lower quadrant pain, fever, and a change in bowel habits, often in older adults. Next, let's look at irritable bowel syndrome, or IBS. Patients typically present with diffuse abdominal pain, often in the lower abdomen, and it is commonly relieved with bowel movements. A key point here is that IBS is a functional disorder, meaning there is no structural or inflammatory pathology. This is why it is a syndrome, not a disease. There are no diagnostic tests. It is a diagnosis of exclusion. Also, it is not inflammatory bowel syndrome, as is sometimes incorrectly stated. The I is for irritable. Building on that, symptoms of IBS are chronic and recurrent, and are associated with changes in bowel habits, such as diarrhea, constipation, or alternating between the two. Individuals often report bloating and gas, but importantly, lab tests and imaging are normal. This leads us to an important clinical distinction. If a patient presents with red flags, such as weight loss, blood in the stool, fever, anemia, or symptoms that wake them at night. We should not assume IBS. Instead, this warrants referral for further medical evaluation. So the big takeaway for IBS: think abdominal pain, changes in bowel habits, and relief with bowel movements. Lastly, let's look at bowel obstruction. Bowel obstruction can be mechanical, meaning there is a physical blockage, or functional, known as ileus, where there is a disruption of normal bowel muscle movement, peristalsis. Pain is often diffuse, but may localize depending on the level of obstruction, and is typically intermittent and crampy early on, progressing to more constant pain as the condition worsens. Symptoms of bowel obstruction are pain that is typically worsened with eating, abdominal distension, nausea, vomiting, and severe constant pain. Also, a hallmark feature is the inability to pass stool or gas, known as obstipation. Overall, this is a condition where red flags are critical. Beyond pain, look for fever, tachycardia, or signs of peritonitis, such as a rigid abdomen or rebound tenderness, as well as another key red flag: absent bowel sounds on auscultation. This is a medical emergency, so this is a key triad. It is progressively worse abdominal pain, the inability to pass stool or gas, and abdominal distension. To wrap this up, I have found that clinical triads are a helpful way to remember many different pathologies. I have also noticed that it helps, both on exams and clinically, if you know where the pain typically presents, the age of onset, and whether the condition is acute or chronic. For example, both appendicitis and Crohn's disease can present with right lower quadrant pain, but appendicitis is acute, while Crohn's is chronic. If a patient presents with left lower quadrant pain, especially an older adult, you should be thinking about diverticulitis. Diverticular disease can be chronic, but when diverticulitis occurs, the tissue becomes inflamed, which presents as acute pain. Ulcerative colitis can also present with left lower quadrant pain, but it is a chronic condition, typically with an earlier onset age-wise. Lastly, with pain that is diffuse, consider the context. IBS is chronic and functional, while a bowel obstruction is acute and often more severe. Overall, putting these together, location, age, and timing, can really help guide your clinical reasoning. That's it for this PT MicroLesson. Like and follow at PT MicroLessons for more fast lessons with big impact on physical therapy topics.